All right, so surgery, traditionally for any therapy and just the same for immunotherapy, our roles mainly involve surgery for diagnosis, surgery for re-biopsy for progression, and possibly in this case biopsy for determination of whether someone's got an adverse reaction, such as pneumonitis. But there are roles for surgery directly related, similarly to Shankar's talk about radiotherapy, whether we combine surgery with immunotherapy so that we get the best bang for our buck out of both. And the work that's going on at the moment is in the neoadjuvant space. Neoadjuvant meaning giving an agent before you do surgery, or adjuvant, which means you give it after you do your surgery. And these are in the settings where you are trying to cure someone surgically. There's also the possible setting of surgery as the adjuvant, in the same way as you can get abscopal effect from radiation. If you actually take a tumour metastasis out, you will cause an increase in circulating tumour cells and circulating DNA, and therefore the possibility of presenting more antigen for immunotherapy to work. The other thing I'll talk about, which was touched on by Shanine early on, is the use of viral agents to try and stimulate a further reaction, or a reaction in patients that normally would be unresponsive to immunotherapy. So just to give an example of what's been happening so far, very little has actually been published with surgery and immunotherapy. The first paper has been mentioned before, was in the New England Journal of Medicine, where they've given the patient a couple of cycles of nivolumab and then done the resection, and they've shown quite high rates of tumour response that we don't even see with standard neoadjuvant chemotherapy, and that was just in single agent. So we had minimal side effects. The only patient death was the patient who fell off a ladder or something, and so we can't really blame that on the surgery. But you'll see grade 3 to 4. Grade 3 to 4 for our non-medical people means that patients either need hospitalisation to treat that, or it's a life-threatening complication, but they didn't die. Grade 5 is death. So you can see here with the plots showing reduction in tumour. Quite a lot of patients had reduction of viable tumour in that biopsy of 90% or more. That was the definition of a major pathological response. And a few of the patients had complete responses. Another trial just reported the other day at the World Lung, showing a different drug, atezolizumab, which has been mentioned before, where they gave that prior to surgery. Likewise showed significant reduction in tumour viability in the sample. So hopefully what's going on in the tumour may also be going on in micrometastatic disease around the body. 3 of these patients had a pathological complete response, and this is in this drug, atezolizumab, no patients who had negative PD-L1 or 0% had any major pathological responses. So that does seem to be predictive in this early cancer setting as well. Another trial adding neoadjuvant chemotherapy with immunotherapy, so now you're really doubling down. They found 9 out of 13 patients had a complete pathological response. That is a remarkable percentage. There are other ongoing trials which we don't have, we only got some early results from. One showing another one with 50% of patients having a major pathological response, 21% having a complete pathological response. There's another couple of trials there which are ongoing, we'll be waiting. So it just shows there's a lot going on in the neoadjuvant surgery space, not just in the later stage. At VCCC, Ben mentioned this study, which we're doing at the moment, which is to give patients immunotherapy versus placebo with a targeted sort of chemotherapy depending on the type of cancer it is. And then the patients that respond, they'll unblind the patients. People who have a good response will go on to atezolizumab afterwards. So that's just a local study. And we have an adjuvant immuno trial which is open at several sites around the VCCC, which is called the BR31 trial. And that's patients who have the later stage, 2 and 3A lung cancers. These are mainly lung cancer patients who we find have got spread to their lymph nodes when we do their operation. Will be randomised to durvalumab versus placebo. And as has been shown on a few slides today, this is the Pacific trial with radiotherapy, looking at stage 3A non-resectable. Well, the group we're looking at is stage 2 to 3A, and with surgery we expect this. This is our own results. And if we were to get a similar improvement to this is not comparable, it's not the reason why I'm doing it, but to show if we were to get a similar result, we'd expect a line like that. So we're rather excited that the Pacific trial has shown such a great improvement in response. Obviously, because we have fewer patients at risk of relapse, because we normally have higher cure rates in the lower stage patients, the benefit won't be in absolute numbers as great, but I'd still rather be on that green line than on the red one. Now, surgery as an adjuvant therapy, traditionally, we often will treat cerebral metastases with surgery because they do cause morbidity, they do cause swelling, and it may be that we may be more aggressive in this setting because we are concerned that cerebral disease doesn't tend to respond as well in many scenarios, although immunotherapy may be different. So it gives an added incentive to perhaps more aggressively do cerebral metastasectomy. What about random metastasectomy? Just like SABRE to a lesion, you could take out a skin lesion that's metastatic quite simply, and that may be enough to cause some antigen release and help with the immunotherapy. Clearance metastasectomy, similar to what we do, for example, sarcoma or colorectal cancer. We've never done this in non-small cell. Well, actually, there is one trial and it showed it was completely useless. The patients had no survival difference if they had every metastasis in their body removed. But that may be a different kettle of fish in, for example, oligoprogressive disease. Do we take out the lesions that are not responding or that are responding opposite to the good responding disease? Node dissection, so removing all the lymph nodes in the chest at surgery. We know in later stage 2 to 3A from randomised trials that it has a survival benefit. It has no benefit in the very early disease, stage 1. But perhaps we should look at the relationship with doing a radical lymph node dissection and response to immunotherapy, and maybe that can be looked at retrospectively in some of these trials like the BR31. It may be that that enhances immunotherapy, it may be that actually impairs immunotherapy, we actually don't know. Viral adjuvants, TVEC was mentioned by Shanine, it has been used in melanoma, not very successful in lung cancer to date. Another agent, and that's a genetically modified organism. There's another agent which is Coxsackie A21 virus, also known as Cavitac. That's a wild type disease, so it's a natural virus. It is responsible for as a rare cause of common cold. It looks for a special target on lung that's present on most lung cancers, binds to that, and then actually infects and kills the cancer. So this is what happens. It gets injected into the patient. It locates the cells by that marker on top of the surface of the cell, replicates, and just like all viral infections in the body, releases more, ruptures the cell, more tumours, more viruses release. It's like a little factory, and then that goes on and infects other cells. Now in the intravenous setting in phase 1 trials, we've seen some very good responses in patients, such as this one in a patient who had become resistant to their EGFR inhibitor. But as we saw in some earlier studies, paradoxically had progression of disease in the brain. So on the horizon, though, is the possibility that we could extend what's been happening in melanoma. This is a melanoma patient who's had repeated injections of the virus into their tumour in the scalp, and you can see progressively quite a dramatic response from what was a very significant and unattractive disease there. It's obviously more difficult in lung cancer because you've got to get to the tumours, and a lot of them are going to be difficult access and will require sort of more enthusiastic, fit patients. But this is something that we're going to look at.